I just wanted to open up by telling you that I didn't always grow up wanting to be a ED specialist or a male incontinence specialist. That wasn't why I necessarily went into medicine, but I went into urology and actually became a cancer specialist. That's really what I do the most of in my surgical practice. For about 13 years now, I've been doing a lot of robotic surgery for prostate cancer, kidney cancers, do a lot of bladder cancer work. And because I take care of a lot of prostate cancer and bladder cancer, a lot of the things we're going to talk about tonight can result from the treatment of those cancers, whether it's surgical treatment or radiation treatment. Both of those can have similar kind of consequences in terms of side effects from either of those treatments. So as I was becoming a cancer surgeon and doing more and more of it, I realized that men were suffering side effects from these kinds of things potentially. And I was sort of saddened that I couldn't take care of them myself. And I made myself an expert actually over time. I became interested in the treatment of ED, I became interested in the treatment of male incontinence, and really looked into training myself to do these kinds of procedures in a more in-depth way, and actually over the years became an expert. And I do go out on the circuit, if you will, once in a while and give these lectures, because I think a lot of the things we're going to talk about tonight are sensitive issues. Many urologists, I'm sure a lot of you probably see other urologists. A lot of urologists don't even talk about these things necessarily. They're not necessarily skilled in how to treat a lot of these things. So I think I prefer to go out on the circuit to at least educate people, and hopefully through these tapings and actually broadcasting on YouTube, we're going to educate a lot more people about what's out there, what's available to you. And I want to share with you tonight some of the things that are out there for you. We're going to go through some definitions of things first and then go into treatments. Let's talk first about male stress urinary incontinence. There's a couple different kinds of incontinence out there, but the definition of incontinence in general is the inability of the valve that normally controls the bladder to hold on to the urine, either because the valve is weakened or because the bladder itself squeezes so powerfully it overrides the ability of the valve to hold things back in. Stress incontinence is what we're going to deal with mostly in our discussions tonight. That tends to be more of what is a side effect of some of the surgeries that we do. But urgency incontinence, which is the intense urge to go, I've got to go, and you can't hold it, that happens a lot in our population of men and women too. It has something to do with the treatments of the cancers that I deal with, but it also has to do with things like enlargement of the prostate, BPH, or benign prostatic hyperplasia. One of the most common signs or symptoms of BPH is urgency incontinence. You can't hold on to it. And that's in the same family, if you will, but we're going to talk more about stress incontinence. Stress urinary incontinence is when the urinary sphincter or the valve cannot hold back the urine. There is a valve at the base of the bladder that normally keeps the urine in there, and in these cases that valve is weakened. How prevalent is it? Well, about 50% of men report leakage of having some sort of stress leakage immediately after the surgery. It's probably even higher than that. But fortunately, after the surgery that we do for prostate cancer, probably about 90% of the men ultimately get better all on their own. It just gets better. Usually with time and with doing these little bladder exercises that we recommend that they do. They're called Kegel exercises to try to strengthen that valve. But about 10% of men don't get better despite all best efforts of them being vigorous about doing those exercises and waiting a long enough time. It just doesn't get better. So that's the most common scenario that we see. And they're quoting somewhere between 9% and 16% of men have leftover stress urinary incontinence after some of the surgeries that we do for prostate cancer. I think it's more on the order of 10%. I think that's a pretty accurate statement of what I think is residual stress incontinence after surgery. And I counsel my men and tell them that that's the true percentage. But worldwide, 500,000 men suffer from this. So let's talk about the process of urinary storage, if you will. There's the bladder. This is the little prostate that's like a little walnut at the base of the bladder. This is kind of a side shot. This is that valve that I'm talking about, also known as the urinary sphincter. And this is the urinary channel that runs from the opening of the bladder through the middle of the prostate, through the sphincter, and then all the way out to the end of the penis. But this sphincter right here is really a muscle. That's what it is. It's a voluntary muscle that you can actually control to some degree. And that's where those Kegel exercises come in. And the Kegel exercises is an exercise, I try to tell my patients to imagine this. If you're standing at the urinal, since mostly there are guys in here, if you're standing at the urinal and you're urinating and you want to cut your flow off in the middle of the urination, try to voluntarily cut it off, you're actually contracting that sphincter muscle. That is a Kegel exercise, and that's what we tell men to do after the surgery. And by doing those repetitive Kegel exercises, you will thicken this muscle. It actually gets thicker. It's like going to the gym and working on your bicep. The more you work the bicep, the bigger your guns are going to be. It's a muscle, and that's the exact same thing that happens here. So in order for the urine to be stored in the bladder and not involuntarily leak out, that sphincter muscle has to be contracted or closed. And for some reason, it doesn't contract adequately, potentially, after the surgery. And in order for you to urinate, that muscle has to relax, and then the urine can flow freely. I've already talked to you about this is the most common cause for male stress urinary incontinence, and that is a radical prostatectomy, which is a surgery for prostate cancer. Whether it's done robotically or done with open surgery, I almost never do open surgery anymore for prostate cancer. Almost all of my surgery is done robotically because it's far superior in just about every way known to mankind. But interestingly enough, the one thing it hasn't necessarily improved on is the overall incontinence rate. It's still 10%. Whether I've done it robotically or done it with open surgery years before that, it's still about 10%. The difference that we do see with robotic surgery is that the men tend to get their continence back much quicker. So instead of waiting 6 and 8 and 10 months, they're getting it sometimes at 1 month and 2 months and 3 months and 6 months. So incontinence will recover more quickly, but the overall level of incontinence is still about 10%. But you can also see incontinence as a result of neurological disorders, certain things like Parkinson's disease or multiple sclerosis. That tends to cause more of the urgency incontinence, not stress incontinence, but the gotta go kind of incontinence. That's from neurological disorders. Other kinds of prostate surgery can sometimes cause urgency incontinence, and maybe too a little bit of stress incontinence, but pretty rare. Radiation therapy can definitely cause incontinence, but it's almost more the urgency incontinence again, not the stress incontinence, so it's a little bit different. Or pelvic trauma, motorcycle accidents, car accidents, pelvic fractures, things like that can cause all sorts of dysfunction and inability to control the urination. So why do we talk about urinary incontinence? This isn't a life and death kind of thing. We're not talking about life and death issues. We are talking, though, about quality of life issues. That clearly is what we're talking about. Because as the men recover from their surgery or from their radiation, and they're still in pads and diapers and clamps and using all these gizmos to try to keep themselves dry, it's completely disheartening to them. It becomes the focus of their lives sometimes. And I don't let guys go too long with this type of incontinence before I recommend some kind of intervention. If I see that it's really not going to get better on its own, or with physical therapy, or with a lot of Kegel exercises and a lot of encouragement from me and my staff, if I see it's not going to get better, I usually recommend intervention with some of the things we're going to talk about a lot sooner than maybe other urologists might. But it clearly is a quality of life issue. It involves social functioning, your general health perception, your mental health, your physical pain, physical functioning. It just affects everything in your whole sphere of your life. Even though it's a quality of life issue, it's not a life and death thing. It really is quite overwhelmingly annoying. What are some of the options for treating male stress incontinence? Let's talk about them. First of all, you kind of have to go see a urologist. It might seem like a fairly simplistic thing to say that to you, but you may hear about people out there that offer treatments for different kinds of incontinence, but really it's a urologist usually that is specially trained for the treatment of, in this case, male incontinence. And in that group of urologists, even many of them don't treat male incontinence. You have to kind of go to a urologist that specializes in male incontinence. So you should find out from your doc, if you're seeing a urologist, do they actually do these kinds of procedures? Because in order to treat them, they have to have training in prosthetics. And I'll show you what I mean by that. The two different options that are available to men for this involve special expertise and special knowledge about prosthetics. What can you do for treatment of male incontinence? We talked about some of these things already. You can reduce your fluid intake. Well, the less you put in, the less that'll come out. That seems sort of obvious, maybe, but that can potentially lead to dehydration and all sorts of other things. I'll recommend things like that for men who have more issues at night, and recommend that they don't drink anything a couple of hours before bed. Something as simple as that may be really helpful to them. I might recommend to them to not drink caffeinated products or alcoholic beverages. That might make a difference for them. Those are simple behavior modification things that they can do that might really help. And then they should also plan to go to the bathroom more often. That might seem like a pretty obvious thing too, but timed voiding by the clock. Go every 2 hours to the bathroom, let's just say, if you can. I don't necessarily recommend pulling the car over off the side of the road, but if you have the option of going to the bathroom in a timed fashion, it might really actually get rid of half of the incontinence, and that in and of itself might be a tremendous benefit. What else can you do? The next step might be send them for physical therapy. It's not the same kind of physical therapy as going to, having had your shoulder operated on and then you go to the therapist and they work that shoulder with various different exercises. This really is a more advanced Kegel exercise, those things that I was referring to just earlier in the conversation. They actually, in a more sophisticated way, make sure that you're doing those exercises properly. You go for a couple of visits. You don't have to go for prolonged visitation there. A couple of visits, they basically make sure you're doing them properly, and then you're off on your own doing them at home. But that can really impact things and make things better. That's the same thing as those Kegel exercises, biofeedback. That all is really the same thing. These are the kinds of things they're doing when you're going for physical therapy. It's the various forms of physical therapy that they'll recommend for you. And then, of course, you can use pads and diapers and catheters and penile clamps, which aren't exactly very pleasant. Men use these things initially after the surgery if they have to, but ultimately their mission is to get out of them. This is not something that you want to be in long term. It's annoying, it's hygienically not satisfying, and it's not a great long-term solution unless they really are so sick that they can't really handle any more aggressive therapy. All these solutions also can be expensive because these pads are extremely expensive and diapers are expensive. Catheters can be expensive, clamps can be expensive. Some insurances will pay for some of these things, but most will not pay for pads and diapers. They might pay for some of the catheters and clamps. And it's also kind of an annoyance, it's uncomfortable, and you really can't be discreet about these things. You always have to plan everything that you do and everywhere you go. So let's talk about some of the things that I do that can sort of put men to the head of the line, if you will, when they're suffering from some of these things. The male sling procedure has been around for a long time. When I originally learned how to do these procedures, this particular sling wasn't invented yet. It was a different kind of sling. This probably has been around now, I'd say, for about 8 years or so. I'm not sure if you can appreciate it from this picture here, but what the sling is a little teeny tiny piece of mesh, which is a woven material, the same kind of material that surgeons will use like for hernia repairs. If any of you had a hernia repair, almost all of them are being done with a mesh material now. And we use this material a lot in women who have stress urinary incontinence. And in fact, this procedure for the male incontinence is quite similar to the procedure that I do for female stress incontinence. And they kind of copied the technique from them, actually. What it is a piece of mesh that acts as a sling or a hammock. It's like a hammock. And what happens is we actually make a small incision underneath of the scrotum is where the urethra lives. That's the urinary channel that lives underneath the scrotum. And we essentially, don't need to give you complete details, but we actually put this little hammock in that area and lift the urethra up out of its unnatural position back to its natural position. And by lifting it up, by putting that hammock in, that extra compression and that change of the angle actually can correct the incontinence completely. The procedure is an outpatient procedure. It takes about an hour. It's a small incision, as I said, underneath the scrotum. The stitches are all put underneath the skin. You are home that same day with a tube or a catheter in your bladder for one night. The catheter comes out the next day. You usually pull it out yourself or if not, you can come into the office and we'll take it out for you. But you have almost instantaneous relief of your incontinence by doing this. This technique is really the way to go for most men who have mild to moderate incontinence. So if you're wearing 2 or 3 pads per day over the course of the day, you would be a candidate for this kind of surgery. If you wear more pads than that, you're probably better off doing this kind of surgery. So it's a perfect segue into that one, and that's called an artificial urinary sphincter. This procedure has been around for well over 50 years. It's an incredibly ingenious little device, actually, that really hasn't changed much in all of my practice, actually. It's virtually the same device as it was 30 years ago. It's a little bit more sophisticated. It's a little bit better materials than they used to have, but it's still virtually the same procedure. There's kind of 3 components to this device. There's this little teeny tiny blood pressure cuff. It looks just like a blood pressure cuff, the thing that goes around your arm, except instead of putting it around your arm, you actually place it around the urethra. And it goes in virtually the same place that I just described where that sling goes in. You put this little blood pressure cuff in around the urethra there. There's this little ball reservoir that's inserted through either the same incision or a secondary incision that goes behind the pubic bone. You'll never feel that ball, you'll never see that ball, but that ball actually contains the fluid that pressurizes this device. This is a hydraulic device. And the third component is this little teeny tiny pump that goes in the scrotum, and that's really the only thing you'll feel. You'll never see anything on the outside. It looks completely normal and natural, but you have to be able to feel this little pump, this little valve mechanism here in order to control this thing. So the way it works is the blood pressure cuff is always closed. So it's like the normal valve. And you start to feel your bladder filling up, and when you feel that you need to go to the bathroom, you basically walk into the toilet, you squeeze this little pump, just one little squeeze. You don't even have to squeeze it very hard. The little blood pressure cuff releases and the urine can flow freely out through the urethra. Automatically, within the next minute, the thing repressurizes itself. So you have to stay in there for about a minute to a minute and a half for the whole process to happen, but it's an incredibly nifty device. You basically feel like you need to urinate, you give one squeeze into this little pump, the urine flows freely, and then it automatically repressurizes itself. This too is an outpatient procedure that we do in our outpatient surgery centers that we have specifically designed for these implant procedures. Also takes about an hour to an hour and 15 minutes to do this procedure. You also will go home with a catheter in your bladder for 1 or 2 nights maximum. There's very little pain associated with this procedure. This procedure specifically is for men who have more significant incontinence. So remember, the other ones for the 2 or 3 pads a day, this would be for the 4, 5, 6, 7, 10 pads per day. So more severe incontinence requires something like this. Very foolproof though, it works well. They are both minimally invasive procedures, but this one clearly is minimally invasive. This is the sling again, because there's no working parts. That's the advantage of the sling. We're just putting a hammock in there. There's no tubing, there's no hydraulics, there's no pumps, there's no reservoirs, there's no blood pressure cuffs. It's a very simplistic little repositioning of the urethra. So why wouldn't you want to do something more simple if you could get away with doing that? And that's the benefit of doing a sling if the incontinence is minimal to mild. The artificial sphincter, as I told you, basically mimics the healthy sphincter, and it really works for men who have worse off sphincter function. But again, this device is completely inside of the body. You could walk around naked in the gym and no guy would ever know that you had this thing in there. It's totally concealed, and the only part you will feel is the little pump in the scrotum. In summary then, those are the 2 procedures that I wanted to just share with you briefly for male stress urinary incontinence. You need to speak to your urologist about whether they even do these kinds of procedures. If not, you really need to seek a urologist that does do these kinds of procedures, but it's all going to depend on how many pads you use, and also it's helpful to keep a little journal of how many times you're wet, how many pads you use during the course of the day, and that really helps the physician figure out what's the more proper procedure for you. Just brief note about the possible risks as far as the male sling is concerned. Sometimes even though we reposition the urethra and put it in perfectly, it doesn't keep it tight enough because after all, we don't want to tie the thing in a knot. You do have to tie it up, you do have to tighten it up, but you don't want to over tighten it because men then won't be able to urinate. So there's a fine line between doing too much and too little. It can lead to urinary retention, just like I said. If you tie it a little too tight, it potentially can result in that. Most of that usually goes away on its own. It can cause some postoperative pain, irritation of the wound site. We rarely see that, to tell you the truth. I haven't had one single wound infection. The artificial sphincter, again, some of the side effects could be urinary retention again. Sometimes if we do this procedure in men who have had radiation treatment, the tissue in there is not as healthy as normal tissue. And when you put a foreign body inside of the body in an irradiated space, sometimes the body kind of rejects the tissue, rejects the implant, if you will. Pretty rare, but possible. So despite all these potential side effects that are listed, they're actually pretty minimal. We see very few side effects with both of these procedures once you get through the postoperative phase. Both of these procedures are very time tested. As I said, they've been around for forever, and we're strong advocates for the use of these two procedures. But again, you have to go to somebody who is experienced. The insurance coverage for these things is not necessarily guaranteed, but they're almost guaranteed. Virtually every insurer that I deal with pays for this because they feel it's a direct result from the cancer treatment, if that is indeed the case, and it's clearly a medical, physical issue. And I've never seen one single rejection for any of these devices, quite honestly. So although it's not a guarantee, it's kind of a guarantee that most likely it would be covered. And in summary then, stress urinary incontinence is a known side effects of prostate cancer treatment and other conditions. We haven't even touched on bladder cancers and colon cancers and different kinds of radiation and chemotherapy for various cancers that can lead to incontinence too. There's several different treatment options. The short-term options can be expensive and uncomfortable. The sphincter and the sling are really good potential permanent options. And again, speak to your urologist and see what they're capable of doing for you.